starting with Libman-Sec. I'm starting with Libman-Sec endocarditis. Libman-Sec endocarditis is atypical verrucous endocarditis. In Libman-Sec endocarditis, the patient have SLE. You know what is SLE? It is an autoimmune disease. The patient have SLE, systemic lupus erythematosus, SLE. What is SLE? SLE is an autoimmune diseases in which body form antibodies against the DNA, double-stranded DNA. So it is a multi-system involvement, right? So here, the body form auto antibodies against heart also. What is SLE basically? Basically, SLE में होता क्या है? You may be knowing that all human cell, the body is made up of cell. From head to toe, we are made up of cell, right? And inside the cell, this is the nucleus. The double-stranded cell, the endocarditis. Libman-Sec endocarditis is atypical verrucous endocarditis. In Libman-Sec endocarditis, the patient have SLE. You know what is SLE? It is an autoimmune disease. The patient, Libman-Sec endocarditis, the patient have SLE. You know what is SLE? It is an autoimmune disease. The patient have SLE, systemic lupus erythematosus, SLE. What is SLE? SLE is an autoimmune diseases in which body form antibodies. Bodies against the DNA, double-stranded DNA. So it is a multi-system involvement, right? So here, the body form auto antibodies against heart also. What is SLE basically? Basically, SLE में होता क्या है? You may be knowing that all human cell, the body is made up of cell. From head to toe, we are made up of cell, right? And inside the cell, this is the nucleus. Inside the nucleus, this is the double-stranded DNA. So in SLE, the body form auto antibodies against the double-stranded DNA. So double-stranded DNA, anti-double-stranded DNA antibodies are formed. Now DNA is present in all organs. DNA is present in heart also. So the heart cells, the endocardial cells of the heart, body will form antibodies against the DNA of that cells, and due to the antigen antibody reactions, the vegetations are formed on the heart. Here only endocarditis will occur. Myo and pericarditis will not occur here. Here only endocarditis will be made, right? So in endocarditis, here also vegetations are formed. But the reason for vegetation here is SLE. What is the reason for vegetation? The reason for vegetation is SLE. Right? It is not molecular mimicry and cross reactivity like RHD. Please differentiate. यहाँ पे भी बनेगी तो vegetation C. See the vegetation C. See the vegetation. Now what is the difference between the vegetations here in Libman-Sec and the vegetations which we have already seen in rheumatic heart disease? What is the difference? See the location. Okay, we will describe the vegetation. In rheumatic heart disease, vegetations were small in size. Here, vegetations are medium size. They are also multiple. In rheumatic disease, they were convex. Here, they are flattened. The meaning of the flattened is verrucous. That's why it is known as atypical verrucous. वहां पे भी वेजिटेशन स्टेराइल थे, यहाँ पे भी वेजिटेशन आर स्टेराइल. देयर इज नो बैक्टीरिया हियर आल्सो. In rheumatic heart disease, the reason was antigen antibody reactions, auto antibodies, cross reactivity. Here the reason for vegetation formation is SLE, right? So there is no bacteria here also. So see, compare the vegetations in rheumatic heart disease with the vegetations in Liebman sac. You can see, you can see. Can you see the size here is small? Yes. Can you see the size here? The size here is medium size. It is not small. Here also, here small, here medium size, right? We can see. Here also multiple, here also multiple. Here also sterile, no bacteria is there. Here also sterile, no bacteria. Give me a thumbs up. Come on. So that is the vegetations we have seen. Now tell me the wall. Which wall? In sterile, cross reactivity. Here also. Here also, tell me the wall. Which wall? In rheumatic heart disease, the mnemonic was MATP. Here also the most common wall is mitral only. Mitral and tricuspid are most commonly involved. You can learn the same mnemonic. But the location is different. Can you tell me the location on rheumatic heart disease? What was the location in rheumatic heart disease I taught you? Ayush, Kishore, Naval, what was the location? The location on rheumatic heart disease was a junction. That is the closure of the walls, right? So here the location is not junction. Here the location is not junction. Let me draw the heart. Let me draw the four chambers. This is the left side. This is the right side. Let me draw the mitral valve to explain the two cusp of the mitral valve. Now this is left auricle. You all can see. This is left ventricle. You can see the two cusp of the mitral valve, the red color valve. These are the two cusps, right? Just suppose my two hands are two cusps. So this is auricle, this is ventricle, these are the two cusps. When the two cusps are separating, blood is coming from auricle to ventricle, and when the two cusps are closing, the blood is not coming. So this is the normal cardiac cycle. We can see they are opening, closing, opening, closing. Now in the upper surface is auricular surface, the lower surface is ventricular surface. Say yes or no. So the two surfaces are there, and apart from it, junction is there. So in rheumatic heart disease, we have seen the vegetations are formed at the junction, neither on upper nor on lower, on the junction. But here in Liebman sac endocarditis, that is SLE endocarditis, the vegetations are formed on upper as well as lower surface, not on junction. It is formed on upper also, it is formed on lower also. So both surfaces have vegetation. Please mind it. Have you got it? Give me a thumbs up if you got it. So upper surface also have vegetation. Lower surface, so upper auricular and ventricular. Both surfaces have surface के ऊपर vegetation, right? So both surfaces have vegetation. Not only this, this is the wall now. The continuity of the wall is the auricular. ये auricle आ गया, right? यहाँ दोनों side auricle आ गया. And the continuity of this wall is the ventricle, right? And the corners are known as pockets. These corners are known as pockets. Pockets. So vegetations are formed on the upper surface and lower surface. They extend to the pocket, and from the pocket they continue on the auricular and ventricular surface. Now see the diagram. The beauty of the diagram I have drawn. See, appreciate it. Have you got it? I have drawn the vegetations on upper surface. Say yes or no. I have drawn the vegetations on the lower surface. Say yes or no. I have continued the vegetations in the corners, that is pockets, and from pockets I have continued on the auricular surface also, and I have continued on the ventricular surface also. So this is the location. Now wait. Both surfaces, upper and lower. Not only both surfaces, along the pockets also, the corners also, and the adjoining ventricular and auricular node also. Everyone gave me a thumbs up. Now see the beauty of the diagram here. The Robbins have shown. See, Robbins ने इसको flip करके दिखाया है. Why the Robbins have flipped this surface? There is no flip in other. There is flip here. Just to show you the vegetations are on upper surface as well as lower surface. Robbins is a great one. उसके डायग्राम में ही सब कुछ है, उसको बोलने की जरूरत नहीं है. Everything is shown in the diagram. समझदार चाहिए समझने के लिए diagram. You got my point? So vegetation is present on the upper as well as lower surface. It is crystal clear in this diagram. No need to say this flip flap. ऐसा उसको उल्टा करके दिखाया है कि देखो vegetation नीचे भी है. So vegetation is on the upper as well as lower surface, right? So you will never forget him, right? So that is the thing. Vegetation is on the upper as well as lower. forget him, right? So that is the thing. It is present on the surface. Now one more thing here, see the two cusp. This is rheumatic heart disease, and see the two cusp here, right? This is ligament sac. Here you can see vegetations are at the junction, not over the surface, and here it is present on the surface. This diagram is from some other book, right? Deformity, यहाँ पे कोई deformity नहीं है. Their deformity was MR. यहाँ पे कोई खास deformity नहीं है. So we are done with ligament. Their deformity was MR. यहाँ पे कोई खास डिफॉर्मिटी नहीं है. So we are done with ligament sac also. So let me compare rheumatic fever with the ligament sac endocarditis. Let me compare. We compare these two, then I start the third one, right? So who will help me in comparing? Anyone? So here the vegetations are small, here they are medium, right? Here they are convex, not written, you can write. Here they are flat. Flattening is a hallmark here. They are flat. They are flat and varicose. Flattening is known as varicose, right? Here they are along the line of closure, that is junction. Here they are both surface, upper, lower. Not only this, they are present on the pocket also, and they are present on adjoining endometrium, auricle and varicle also. So that is the complete story, right? Here the reason is rheumatic fever. Antigen antibody, auto antibodies are formed, and here the reason is acid, right? Here they produce fish mouth deformity, buttonhole deformity, and MR. Here they do not produce any deformity, right? Here you can see they are sterile. Here also they are sterile. So sterile is a common feature. Shall I come on the third? I'm starting the third one. Non-bacterial thrombotic endocarditis known as NBTE. Non-bacterial means it is not infected. The fourth one is the bacterial, no? The last one will be infective or bacterial. This one is non-bacterial. Non-bacterial. Okay, non-bacterial. Then what is the reason? The reason is thrombosis. Thrombosis will occur. Thrombotic endocarditis. So see the meaning of the name. नाम में ही उसका मतलब छुपा है. Non-bacterial. Here bacteria will not come. It is also sterile, right? Bacteria will not cause the lesion. The lesion, the vegetation is due to thrombosis in the wall of the heart. In the wall of the heart, thrombus will form, and that thrombus, actually the thrombus is a nodule that will form the vegetation. So that leads to endocarditis. So non-bacterial thrombotic endocarditis, here also vegetations are formed. So since here the vegetation is formed by the thrombus in the heart, in the wall of the heart. So again they are sterile, bacteria is absent. And why the thrombus is formed? It is the hypercoagulable state. So sometimes blood becomes hypercoagulable, and without injury it starts forming thrombus. Multiple microthrombi are formed, and the microthrombi are present in the walls of the heart, right? So that is the reason. So reason here are formed. And the microthrombi are present in the walls of the heart, right? So that is the reason. So reason here is hypercoagulability. What is the reason in rheumatic heart disease? The reason in rheumatic heart disease, the reason for vegetations is rheumatic fever. That is molecular mimicry and cross reactivity of antigen antibody reaction. What is the reason in ligament sac? The reason in ligament sac is SLE. What is the reason in NBTE, non-bacterial thrombotic endocarditis? The reason here is hypercoagulability of the blood, which leads to thrombus formation. Crystal clear concepts. Shall I proceed ahead? See the vegetations here. Can you see the vegetations here? Can you see the vegetations here? Here vegetations are again at the junction. Again at the junction, like rheumatic heart disease, the first one. So again only at the junction you can understand the meaning. So here vegetations are again small or medium size. They are more friable, they are sterile, and they are single or multiple or medium size. are more friable, they are sterile, and they are single or multiple, and they are present at the junctions. They are again present along the line of the closure and junction. The walls are same, मटक ये हमेशा सेम रहेगा. The mnemonic is same मटक. So most commonly all the vegetations are on neutral wall. Compare rheumatic heart disease. The first one I taught you. The second I taught you is ligament sac, and third currently I am teaching you is NT. So first comment on their size. Here I can see all of them are small. Here I can see they are medium. Here also I will say medium. Here they are multiple. Here also multiple. Here also multiple. Everywhere it is sterile. So I will write sterile, sterile, sterile. But the reason is different. Here the reason is rheumatic fever, antigen antibody reaction, autoantibodies. Here the reason is SLE, and here the reason is hypercoagulability of the blood leading to the Thomas condition. Give me a thumbs up. Now tell me the location. The most important point to be taken care of is the location. Who will tell me the location? Here the location is line of closure. That is the junction. In rheumatic heart disease, right? In SLE, the location was both surfaces, upper as well as lower. Apart from it, pockets, you can see both surfaces. Apart from it, upper and lower. See the flip flap. Apart from it, pockets and adjoining. Endometrium also, right? And here also it is present on the junction. That is line of closure. So can I say the location is same in RSD and NBTE? In rheumatic heart disease and non-bacterial thrombotic enterocolitis, the location is same. Location is important. See the size, see their number. Size is different, small, medium, medium. Number is same, all of them are multiple, right? See whether they are sterile and bland. All of them are sterile till now. The fourth one, ये वाला non-sterile होगा, it contains bacteria. This is non-sterile, it will be infected, right? The fourth one which I am going to teach you next, right? See the location, right? That's important. See the reason why they are found. So in this way you have to compare the vegetations. Give me a thumbs up. Ayush, Kishore, are you people there? Give me a thumbs up. Give me a thumbs up. So see the diagram. Can you see NBTE vegetations? See they are present on the junction. They are present on the junction. Only on the junction. And see they are medium size. They are on the junction, right? So and deformity here also nodules are found. No severe deformity. So that's about it. So we are done with the third also. Till now we are done with three. Can we compare the three to start the fourth one? The last one I will teach you then. Rheumatic fever, Libman sac, and NBT. Till now we are done with three. Can you help me? Yes. These are small. These are medium. Make it medium also. ये गलती से small लिखा. These both are medium. Tell me the reason. This is seen in rheumatic fever. This is seen in SLE. This is seen in hypercoagulability. Right? Tell me the reason. Right? Tell me these three. All three are sterile. All three are sterile. The next, tell me their location. Location. This is along the line of closure. Along the line of closure, and this one is on the both sides. This is the most simplified way I can teach you. Which are flat. These one are flat. SLE वाले अलग से flat याद रखना. Don't forget. Have you got it? Naval, Kishore. Coming on the last one. The last one are impactive endocarditis. So before the, coming on the flat याद रखना. Don't forget. Have you got it? Naval, Kishore. Coming on the last one. The last one are impactive endocarditis. So before that, would you like to do some questions based on these two NBT and Liebman-Sack? We will so do few questions. So this is the first question in front of you from the previous year question papers. Can you tell me the answer? Anyone of you? Flat vegetations are seen. Flat vegetations are seen in the pockets of the wall. So दो clues हैं. There are two clues in the question. Pick the clues. Number one clue, the vegetations are flat. Number two, they are present in the pocket. So दोनों clue combine करते हुए, what is your answer? Kishore, absolutely right. So only Kishore want to participate. What about others? What about others? Yes, Naval, absolutely right. Yes, very good. So it is Liebman-Sack. Fatima, very good. Liebman-Sack. So two clues were in the question. You know the answer. Correct answer is B. So it is Liebman-Sack. The vegetations are flat and they are in the pockets. Right? So correct answer is B. Yes, Ayush. Very good. This is the next question in front of you. Which type of endocarditis have vegetations? Okay. On both sides of the wall. On both sides of the wall. Upper surface as well as lower surface. Upper and lower. Upper and lower, both sides of the wall. What is your answer now? What is your answer now? So yes, again the answer is Liebman-Sack. Again the fever, they are present along the line. Again, they are अभी पढ़ाया नहीं. Only on upper. So say the summary. I'm telling you. Present at the on both read the question. Right? So all are right. I'm changing. What is the automatic? On lower the location. Next question in front of you. This is the next question in front of you. Vegetations in Liebman-Sack. Liebman-Sack. Can you describe the vegetation? Read the four options. Which option is best suiting? I'm giving you time. Describe the large overflow. There are media, yeah, but not specific. Okay, the ball, below the ball. In which of the following below vegetations are present on below? Below से मेरा मतलब है lower surface. Lower surface. Not is a tricky question. Question is simple, but yeah, yet tricky. So the four type of endocarditis. Lower person, yes, Kishore. Greater person, both. So both includes lower also, na? Yes, Kishore. So both includes lower also. So that what is the summary? In rheumatic fever, at the junction. In NBTE, at the junction. In Liebman-Sack, it is at both. Both includes upper and lower. You got my point for the last one. You want me to continue the last one? It will take another 10 minutes. I will finish. The topic will be finished, but now right? So infective or bacterial endocarditis, one and the same thing. Either you say infective or you say bacterial. It is one and the same thing, right? So infective or bacterial endocarditis, it is little bit larger, right? So I will give you a little bit detail here, right? So infective or bacterial endocarditis, what's the reason for vegetation formation here? The reason for vegetation formation is the bacteria. The bacteria will come and it will form the vegetation. The bacteria will destroy the wall, and due to the destruction of the wall caused by the bacteria, a nodule will be formed there, and that nodule is known as vegetation. So vegetations are infected, they are not sterile, they are not bland, they contain bacteria. In contrast to other three endocarditis where the vegetations were sterile. Here vegetations are due to bacteria only, so how they can be sterile? They cannot be sterile. Now it is of two types, abe and sabe. What is the, they can be sterile? cannot be sterile. And they here vegetations are due to bacteria only, so how they can be sterile? They cannot be sterile. Now it is of two types, abe and sabe only, so how they can be sterile? They cannot be sterile. Now it is of two types, abe and sabe. What is the full form? Acute bacterial endocarditis and subacute bacterial endocarditis. The two types, abe, sabe. Acute, subacute bacterial endocarditis. Now listen a story. I'm telling you a story. Everyone. Acute. Two hearts in front of you. Of course, you all can see the two hearts in front of you. Let me tell you a story of the two hearts. The first patient is a healthy patient. He is having healthy balls. This mitral wall is absolutely healthy. The second patient is already having a disease in the mitral wall. So that's why prosthetic wall are here. The healthy walls are not there. The heart walls are weak and they are prosthetic. They are prosthetic, right? So since here the healthy wall is there, a bacteria is coming. So the bacteria which want to cause the damage to the healthy wall, that bacteria should be highly virulent. Say yes or no. And here the walls are already damaged. They are already prosthetic. They are artificial walls. So here even a less virulent bacteria, less powerful bacteria can cause the damage. Agree or do not agree? Here the walls are healthy, they are strong, and healthy walls are there. So strong bacteria is required. Highly virulent bacteria is required to damage. Right? The example of highly virulent bacteria is Staph aureus. Staph aureus. Staphylococcus aureus. Staphylococcus aureus will cause the damage here. And here, when the walls are already prosthetic, damaged, weak, so even a less virulent bacteria can cause the damage. So example of such bacteria is Streptococcus viridans. It is not Staphylococcus, it is Streptococcus viridans. So learn the name of the bacteria, right? Now here, since I have told you, the bacteria is highly virulent, so in less than 6 weeks, it will cause the damage, right? And here, since the bacteria is very weak, bacteria is less powerful, so it will require more than 6 weeks to cause the damage. So this is practically Abe, this is practically Sabe. Give me a thumbs up. Give me a thumbs up. Abe is acute, it is very fast, less than 6 weeks, the walls are damaged. And Sabe is practically very slow, so it requires more than 6 weeks. So same story is written in front of you. Here the walls are healthy, here walls are diseased. Here more powerful bacteria is required in front of you, practically very.
तेरे नैना तेरे नैना तेरे नैना रे तेरे नैना तेरे नैना तेरे नैना रे तेरे नैना तेरे नैना tricuspid valve, mitral valve, right, left. This valve is healthy, so a highly virulent bacteria is needed to cause damage, which is the Streptococcus aureus, which causes the prosthetic valve disease. And since this is highly virulent, so it will cause damage in less than yeah, less than 6 weeks. So it is the acute And by taking the example, taking the another example, tricuspid, mitral. So this is not healthy. This is a prosthetic, already damaged wall, and a highly virulent or low virulent bacteria like the Streptococcus viridans, which also cause prosthetic heart wall disease, stick to catheters, viridans. Hmm. So it will need greater than 6 weeks to cause the damage. So that is the subacute.
very slow. So it requires here more powerful bacteria is required. Here less virulent bacteria bhi chalega. So here Staph aureus less than 6 weeks. Here Streptococcus viridans more than 6 weeks. This is Abe. This is Sabe. Now you will never forget. Give me a thumbs up. So tell me what is Abe. What is acute bacterial enterocolitis? Here a highly virulent bacteria is required, like Staph aureus, because the heart walls are not good. That's why highly virulent are required. And since the bacteria is powerful, highly virulent, in less than 6 weeks it will damage the bone. It will produce the vegetations in less than 6 weeks. Right? What is SABE? What is SABE? Subacute. As the name indicates, it is subacute. It is not acute. We got it even a lab. So ज़्यादा virulent bacteria की जरूरत नहीं है. The example here is Streptococcus viridans, right? And since the bacteria is less powerful, less virulent, so it requires more time. It requires more than 6 weeks to do the damage. So one is Abe, one is Sabe. So see the differences between Abe, Sabe. We have already seen here less than 6 weeks, more than 6 weeks. Highly virulent bacteria, less virulent bacteria. High virulent bacteria, the example is Staph aureus. Less virulent bacteria, the example is Streptococcus viridans. This is Staphylococcus, this is Streptococcus. Right? Here, previously the heart walls are normal. Previously the heart walls are damaged. So one is Abe, one is Sabe. We have seen that. Now coming on the etiology, we have already done the etiology. I'm skipping it, right? So in Abe, it is Staph aureus. In Sabe, it is Streptococcus viridans. We have already done that. Let me skip it. There are many predisposing factors if the heart walls are previously damaged. So because of all these conditions, the heart walls can be previously damaged, right? Okay. So bros already know in Sabe the heart walls are previously damaged. In Abe they are normal. We already know these points. Yeah, coming on the directly vegetations. Here the vegetations are large. So compare the four vegetations in size. In the first rheumatic heart disease they were small. In Libman sac as well as NBT, both
Medium.
of them they were medium size, and I'm saying now they are large. So small, medium, large. If you are talking in a sequence, right? Here the vegetations are large. इतने बड़े कि they are friable, वो टूट ही जाएंगे वहां से. Can you see the
Oh.
diagram? Here I will draw the vegetations. Can you see the vegetations? They are big vegetations, big one. इतने बड़े कि they will just split from there. They will just degrade from there. So they are highly friable. Since they are large, they will टूट जाएंगे. जितना बड़ा है टूटने के chances उतना ज़्यादा है. So the size is directly proportional to the friability, I want to say, right? So they are large, they are friable. They can be single, they can be multiple and irregular. They are very bulky. They are very bulky. Grossly, if you talk about. So tell me the location. And you see the four walls I have shown in the diagram. In all four walls, I have seen, I have drawn them on the upper surface. Only on the upper surface. So it can occur, the sequence is same, but the sequence is same. Most common mitral, least common pulmonary. But in all of them, they occur only on upper surface. Everyone give me a thumbs up. Everyone. One more point I would like to highlight here, whether you get it or not, I don't know. These walls are known as auriculoventricular wall, atrioventricular wall, because they separate atria from the ventricle. So mitral wall and tricuspid wall are known as atrioventricular wall. I guess you know that. And these two walls, pulmonary and aortic wall, these are known as semilunar walls. Semilunar walls. You know that? I guess you know that. Right? Now let's talk about atrioventricular wall. On which surface the vegetations are there? Vegetations are only on upper surface. Right? Vegetations on all of them are on upper surface. But let me tell you what is the upper surface in AV wall, what is the upper surface in semilunar walls. देखो wall देखो, see the walls. See the walls. Okay. See the wall here. See AV walls. The upper surface of AV wall. Can you see it is atrial surface? Atria में जा रहा है upper surface. And lower surface is the ventricular. So can I say in AV walls it occurs on atrial surface? Atrial means upper surface. Yes or no? And can I say in semilunar walls? What is the upper surface of semilunar wall? In semilunar wall, the upper surface is ventricular surface. The lower is either aorta or pulmonary vein. This is aorta, this is pulmonary vein. Give me a thumbs up. Give me a thumbs up. So semilunar wall, the upper surface is ventricular. Semilunar walls. What is the upper surface of semilunar wall? In semilunar wall, the upper surface is ventricular surface. The lower is either aorta or pulmonary wall. This is aorta, this is pulmonary. Pulmonary occurs on the upper surface of AV wall. Can you see it is atrial surface? Atria में जा रहा है upper surface, and lower surface is the ventricular. So can I say in AV walls it occurs on atrial surface? Atrial means upper surface. Yes or no? And can I say in semilunar walls? What is the upper surface of semilunar wall? In semilunar wall, the upper surface is ventricular surface. The lower is either aorta or pulmonary wall. This is aorta. This is pulmonary vein. Give me a thumbs up. Give me a thumbs up. So in AV wall, it occurs on atrial surface. In semilunar wall, it occurs on ventricular surface. अगर ये समझ में आया तो अच्छी बात, नहीं समझ में आया नोट मत लो, just not upper surface. It always occurs on the upper surface of all walls, right? Learn this something. So what is the location? What is the location? So see, where I have written this. What I have told you, I have written it somewhere, ना? आएगा कहीं ना कहीं आएगा, ठीक है? So can you see the four diagrams now? See all four diagrams, they are in front of you. See infective endocarditis. This one. See the vegetations. They are bulkier. They are large. Here I have shown only single. All of them are multiple. Usually it is bulky and single, but can be multiple. See the size. Compare the size. Compare the size. Here they are small. Here they are medium. Here they are medium. Here they are large. Since they are large, they are fragile. They are fragile. See the location. Can you tell me the location? Here it is the junction. Here it is the junction. Here on both surfaces along with pockets, and here only on upper surface. Only on upper surface. So you got it. The mnemonic is same, but that you don't have to bother. The mnemonic is same everywhere, matter. Right? So most common wall involved is mitral wall. Always mitral wall. Location. Read the location that I was telling you. So it is the atrial surface of AV wall and ventricular surface of semilunar wall. This line is given in drawings. So मुझे ये समझने में बहुत टाइम लग गया था, but you got it. So I mean upper surface of all. Upper surface of all wall. Have you got it, everyone? So atrial surface of AV wall and ventricular surface of the semilunar wall. So it is the upper surface of all walls, right? So that is, and here also it can go to the pockets and adjacent endometrium like ligaments, right? Here also it can be. So we are done with that. You can see they are very destructive. You can see the vegetation, right? They are present on the upper surface. They can ulcerate, they can perforate, they can cause the abscess. यहाँ पे pus भर जाएगा. Inside the vegetation, pus can be there because bacteria is there. So you can see pus-filled vegetation. They are purulent. They are pus-filled. They form the abscess. They ulcerate. They perforate. So most destructive among the four, they are the most destructive. Most destructive because bacteria is present in them. Most destructive as compared to others. So they ulcerate, they perforate, they form abscess, right? And the most destructive one are the vegetations of infective endocarditis. They are the largest, they are the most tribal, they are the most destructive. Give me a thumbs up. Everyone give me a thumbs up. Everyone. So can we compare the four and end this lecture now? So थोड़ा सा portion बचा है. One more portion which is remaining that you have to read by yourself. Okay. The complications of this one. Infective. So cardiac complication, in the cardiac, they will form abscess. They will form abscess inside the wall. The abscess form in the wall. That is the most common complication in the heart. And extracardiac. You can see pus-filled abscess. Please appreciate the pus-filled abscess. These all images are from bronchus and they come for image-based questions, right? And extracardiac complication. Why extracardiac should happen? Right. Listen, any vegetation on the left side of the heart. I said the vegetations are large and they are friable. So they will split. Once the vegetation is split, it is friable. It is known as ambulous. It is known as ambulous. It is no more vegetation now. Once it will get split, it is ambulous. So all left side vegetation which will get split, they will go in aorta. They will go in aorta and obstruct the various organs in the aorta. Right? All the vegetation on the right side of the heart, they will split and they will go in the pulmonary vein and they will go in the lungs. Am I right? I guess I am right. So all the vegetations on the right side of the heart, they will obstruct lung. And all the vegetations on the left side of the heart, they will form ambuli and obstruct aorta and go to the various organs. So extracardiac, so the same diagram is drawn here, right? From the left side, they are going in aorta. From the right side, they are going in the lungs. From the left side, from aorta, they can move technically to any organ. So see the extracardiac complications. So they are going to the hands. From the aorta, they are going to the nails and the hands, the fingers, right? And they can produce lesions here. So two type of lesions are formed. One is Janaway's port, one is Osler mole. These two are extracardiac complications of infective endocarditis. Janaway are seen in Abai and Osler are seen in Sabe. Let me write here. Janaway are seen in Abai and Osler are seen in Sabe. Let me write here. This is Osler seen in Sabe and this is Janebe. Janebe. They are seen in Abe. First learn that. Janave in Abe, Osler in Sabe. You know what is Abe and Sabe. Now what is the difference between them? Let me tell you the difference. You can see Osler is present at the tip of the finger. They are painful, number one. Painful, pain is present. And they are present at the tip of the finger. Tip of the finger. Right? Here, Janave, they are present on the palm, not at the tip of the finger. They are present on palm and they are not painful. Pain is absent here. Pain is absent. You got my point? Say yes or no. So typically, crystal clear in the diagram. You can see Osler, you can see Janave. This is the tip of the finger, this is the palm. So here pain is absent, here pain is present. I'm little bit fast because मुझे खत्म करना है session, right? So Osler are seen in Sabe and Janave are seen in Abe. Both are due to extracardiac lesions seen in the heart. Now, the last thing you read by yourself is the Duke criteria. I taught you rheumatic heart disease, the first endocarditis, right? In that, I told you Jones criteria, the major, the minor, 5 major, 4 minor, and gas criteria. Now, I'm teaching you infective endocarditis. In infective endocarditis, there are Duke's criteria, the major and minor, right? So, instead of Jones, यहाँ पे Duke's criteria है, but you read by yourself. There are 3 major. I'm not reading them. Read the 3 major. Read the 5 minor. So these are the Duke's criteria, right? So I am done. I guess I am done with the 4 type of endocarditis. I am done, but there are questions based on infective endocarditis. But I'm unfortunately ending this session. So you can ask for the notes. I will send you my PDF, which currently I'm teaching you. You can read from my notes, or my notes are from Robbins only. Robbins, Hirschmohan, and few other textbooks combining all of them. So you can ask the notes on the Telegram. I will share it with you. And I'm ending the session right now. Thank you very much for being with me. If you like the lecture, don't forget to click on the like button before leaving the session.
यारा लाइट आए तेरे नैना तेरे नैना तेरे नैना congenital heart disease. तेरे नैना तेरे नैना. Okay, we are going to do polls. Oh, sorry. BCQs on endocarditis. Pathology. So the tip is that always do BCQs after your steady session. It quite helps. So don't forget to do your BCQs. Okay, these are all the clinical features of rheumatic fever, which we already know. These are the complications. Extra cardiac, what the Jones, cardiac manifestation, encarditis, These are all the infective endocarditis. Arthalgia is a pain and arthritis is the inflammation. These are all the findings which will on the Eschoff nodule, which is like the modified macrophage. Anti-Eschoff is also modified macrophage, but it has its own characteristic. This is seen as the myocarditis. This is the endocarditis, where there is two things like SOS, which we read the acute and subacute. Vegetations are the thickening on when the wall becomes thick and loses translucency. So we call it a vegetation. It usually grows on walls or either cups like upper lower. Okay, rheumatic fever usually follows an infection with. Check your understanding with MCQ. Rheumatic fever usually follows an infection. Rheumatic fever follows an infection of the Streptococcus pyogen, which is the group A. Streptococcus A is the right answer. One of the tests that is done to confirm diagnosis of the rheumatic fever. So it is the anti-streptolysin O, which is the gas infection. In gas infection, there are the three things. First is a throat swab culture, which we do, and second is the serology, in which the anti-DNSP and anti-streptolysin O is used. So that correct answer is C. To diagnose a patient with rheumatic fever, the patient should have at least the patient should have at least two major or one major and two minor. So let's see where it is one major and two minor. So it's A. Which wards are commonly affected by rheumatic fever? Commonly affected are the mitral and tricuspid. So it is A. Actually, it is there is the mnemonic, which is MATB, MATB. So subacute endocarditis usually follows an infection with like the SAB, which the infection is followed by the in SAB there is the less virulent bacteria. The less virulent bacteria is Streptococcus viridans. Okay, so the patient with rheumatic fever comes with a dancing movement. A dancing movement which is known as step dance is the Stedham scoria. Actually, see. So we are done with MCQs. I guess these all are right. One of the complication of endocarditis. The complication of endocarditis is like the abscess, but yeah, the most common complication. The Liebman-Sack endocarditis associated with SLE, because body is made up of cells, right? And as in SLE, what happens? Mm, those cells contain DNA, so body make antigens against DNA. So heart is also made up of cells and made of DNA. So that is the cause of Liebman-Sack endocarditis. Hmm. I told this already. The most common site for Eschoff bodies is the myocardium. Where can we most commonly see McCallum's plaque? So it is commonly seen in the left atrium. What's the most common bacteria in the drug abusers? Hmm. So drug abusers are the Streptococcus viridans. No, wait. Stephen epidermis, no, aureus, aureus. I'm going for Stephen viridans. No, it is the Streptococcus aureus. Okay, what's the most common bacteria in the drug abusers is the Streptococcus aureus. Hmm. I guess the drug abusers when the valve is weaker, so those are not healthy. So it should be validated. But in key it is C. Probably some mistake, I guess. Yeah, or I am wrong. Which of the following on anti? It is the macrophage. Okay. What? Which of the following walls is most affecting drug abusers? So it is the mitral wall. No, it is the tricuspid wall. Sorry. Okay. Chordate India rupture is the future of which of the following? Is the rupture chordate India rupture is the future of which of following? Hmm. Oh, I know. It is the rheumatic fever. The complication. No, the rupture is the chordate India rupture. So basically, why rupture happens? Due to the endocarditis, I must say. Yeah, it is endocarditis because um, the last endocarditis, which is the bacterial endocarditis, in which um, the vegetations are fragile, so they burst out and produce a cardiac complications. Common is abscess along with the cardiac tender. So, what is the incorrect regarding mitral valve disease? Hmm, I haven't read this mitral valve disease, but let's have some guess. In mitral valve disease, the shortening of cardiac tender. Yeah, we cannot avoid this. Mucus secretion inside the wall. Hmm. Thickened fibrillary leaflets. That is the ballooning of the mitral valves. So A and D are similar, so those are correct. B and C, shortening of chordae tendineae, and mucus secretion inside the walls. So the answer should be B, I guess. Incorrect, because if we see there is inflammation, so the walls should be, or the chordae tendineae should be thickened, not shortened. So I am going for B. Yeah, C. So, which of the following is a complication of floppy mitral valve disease? Okay, floppy mitral valve disease, the elongation of, I guess it is nothing happens, no elongation. It could be elongation, yeah, elongation. So, acute and subacute endocardial cause of which bacteria? Aureus and Viridix B. Yeah, it is what? Aureus and Viridix C. So acute is caused by RS and this ovarian. Which of are the complication of rheumatic fever? It is a heart failure, wall regurgitation, damage to heart muscle, all. So which type of endocarditis has relation to increased coagulability? It is obviously the, no, it is the, no, this is not carcinoid, no, all types not the merantic. Okay, we done this and we have quite good score. We scored the, just one question was wrong, and that was this. What's the most common bacterial drug abuser? So it is the OS. I just forgot the micro one. Okay, let's solve this one. I'm not looking at answers, so don't be like he's looking at answer. The condition associated with the highest risks of developing infective endocarditis. Okay, we are talking about the infective endocarditis. So the condition associated with highest risk of developing infective endocarditis is the Mitral valve prolapse with regurgitation, the presence of prosthetic heart or rheumatic fever. Highest risk, obviously the valves which are damaged, so in the presence of prosthetic heart because the wall is already damaged, so if it is in risk, which of the following organisms not common implicated? Okay, the streptococcus species is used, staphylococcus also used, enterococcus and canidia. Hmm. So canidia species causes the vaginal disease like STI type. So our yeah, so it the C is done because enterococcus species do cause the prostate heart valve disease. It is usually caused by virus group, cryptic mutants, mites, streptococcus, urinary tract infection, and told you enteric yeah, UTI. It is PVR positive. A 64-year-old when present images with a chest pain, fever, fatigue, and arthralgia. So these are the symptoms of the rheumatic heart disease. His past history is significant rheumatic heart disease and dental procedure few weeks before admission. On physical examination, there is no like findings, although endocarditis is suspected. The most likely organism is okay. So physical examination, like in the skin, in the joints, in is like mm, subcutaneous. There is nothing like symptom of endocarditis, which we call rheumatic heart disease. Jones criteria. So it's past medical history is significant and the dental procedure before admission. So dental procedure. So it is the viridence because dental plaque or it is related based on the recent IE infective endocarditis diagnostic criteria. The two most important parameters for diagnosis of this infection are laboratory abnormalities and positive blood culture. Positive blood culture is one which is needed. Positive blood culture is echocardiographic changes. Yeah, this is good because in echocardiographic changes we will see the dilated heart. So yeah, and the positive blood culture will give us clue of the bacteria and which 45-year-old woman is scheduled for a dental extraction. She is still rheumatic heart disease with mitral regurgitation. Okay, so she has a history of repeated heart disease with mitral regurgitation, which is like the acute, rapid and acute rheumatic fever heart disease. So she is allergic to penicillin. Has been asked whether she should receive antibiotic prophylaxis before her procedure. The most common response is yes, she should receive the penicillin, but it should not be. It should be else. It should be something like cephalosporin or the yeah, clindamycin is good. Cephalaxin, it is a cephalosporin, but the person who is allergic from penicillin should also avoid those things because the mechanism of action is same. So yeah, the B is most correct because this is also the form of penicillin, ampicillin. So which of the following peripheral administration causes a painful noticeable occurs? So there are two types of nodules, oscillars and janway. Oscillars occur at the tip of the finger and it is a painful sorry finger. Which of the following is not celebrated treatment strategy for bacterial endocarditis? Well, this is all about the pharmacology, but we can do this. So it is the following not a suitable treatment strategy for bacterial endocarditis. Intravenous antibiotic for broad spectrum pending results of the culture, long-term oral antibiotics. Which are the following that not a suitable treatment stage for not a suitable. So long-term oral antibiotics. Corticosteroids are good. Long-term oral antibiotics on cultural results. Intravenous are good, but these are all good. Broad spectrum pending results. I guess B is not good because C is also given if the person is having not want to have the IV. Or is D? It is not the suitable treatment. Bacterial. Oh, it's asking for bacterial endocarditis. Yeah, in bacterial we should avoid the corticosteroid doses because of the immunosuppression effect. I was thinking about the rheumatic heart disease, so that was my bad. Endocardial prophylaxis is recommended in following condition before extraction. Um, no idea about this. Which of the oral procedure will not need any antibiotic prophylaxis to minimize. Okay, this was which of the following assessment is period for diagnosis of the yeah. So diagnosis of the infective is the blood culture. Actually, the this is dentistry. That's why the many question was from dentist side and pharma. I see, I see. So PR interval is increase. S to S for the sound. This is good. We can ask the question with it. Why the outfitters is on my screen always? Am I the brand ambassador of outfitters now? Looks like. Do you guys take breaks? After 1 hour, I'm also tired. I want 5 minute break. I want a 5 minute break. Mhm. There is concern. Oh no, it's OG versus Enigma. Damn, the first game. It should be introduced as this, and then Enigma need to win this upper bracket final, which is against it will be against Tundra, and then go to semi-final. Okay, I can see the split. Can see the ray of hope. You only need to win one player. Damn. The guys is having losing streak. They are pretty bad, that's why. तेरे नैना तेरे नैना तेरे नैना ने Okay, we are done with our break. Now we are starting again. This phonocardiogram image is most consistent with which of following: systolic recurrent inflammatory arterial systolic ejection. So yes, the sound is when produces altitude temperature relaxation. Okay. I have no idea about this. So the findings have most increased the degree of suspicion for bacterial endocarditis in dogs. Bacterial endocarditis will cause a fever, new cardiac mania, shifting not a D. I'm having suspected A because fever, a cardiac normal. Yeah, it's A. Not suitable is the immunosuppression, which is the fire is not equally produced factor by vector and not recognized pre-dispose factor. Yeah, why this shall not recognize predisposing factor? C, because C is hypertrophic cardiomyopathy. What the heck? Why are you talking about cat? Okay, and it is talking about dog. Am I reading this? This is not. Most commonly affected is in infected. So these are the chamber surrounds. Infective endocarditis, which the superior surface is involved. So it should be the chamber of walls. No? The patient damage the wall leaflets, leading to obligation nerves to irritation. Okay. Yeah, it is at the wall. The majority, yeah, the majority of organisms in vegetations are inactive, inactive whatever. Majority are the whatever. Hmm. B, I guess. Very active, but do not premature. Clinical value is the embolization. Embolism is the right, but B is also right. So it is E. Most tube criteria. Oh yeah, modified tube criteria. Highly sensitive, highly specific. C. The modified tube criteria are highly sensitive, designed to kill that may have a clinical and okay. This correctly classified into the specified to category based on major criteria. Okay, so major criteria for possible REG to category based on the major criteria include multiplication, microorganism, and separate blood culture. And endocrine of which let's go antimicrobial therapy, NIE, which is infective endocarditis, antimicrobial therapy. Nephthera will rapidly grow. No, all bacteria vegetation need to be not need to be there. It should be D. The controlment allows to reduce the bacterial. Oh, so some should be killed and some should be killed by the immune system. Hmm, got it. Which is species of bacteria typical causes infective endocarditis? So it is the Staphylococcus in children with um, coronary heart disease. This can rarely cause infection. Coronary restricted. So yeah, because his heart is already weakened, so it should be the streptococcus viridis which will cause the infective endocarditis. This is the effective diagnosis. Hmm. So is effective diagnosis effective endocarditis because yeah, it is due criteria. No, it is electrocardiography effective. Okay, I am. Which of the following decharacterize the major criteria for infective endocarditis? तेरे नाना तेरे नाना तेरे नाना This can be indicator of an infection in the heart walls, which is a common complication. The patient this can be indicator of infection in the heart walls and common complication. Blood culture. Light eye. stopping our stream now. So stream for 3 viewers.